think that the field of immunotherapy is really galloping or moving very fast. I don't believe we had in hematology so profitable years for many years that give hopes to the patients, and with such huge and fruitful development combating leukemia and other type of lymphatic malignancies. So till a few years ago, transplantation was the only successful and only way of immunotherapy, because after all, transplant is based on the immune attack of the cells from the donor against the leukemia of the patient, which we call graft versus leukemia. This is very strong attack, and if you can focus it against the leukemia, it's very fruitful and successful. And so transplant for many years was the example of adoptive cellular immunotherapy, or for the ability of the immune system to actually cure patients with leukemia. However, transplant is with some toxicity, especially that the median age of leukemic patient is 72, and the risk of transplant is correlating with age. So not every age is the same, not every 70 age people is the same, but still. And so in the last year, we have a development in both humoral and cellular immunotherapy, so both antibodies and cellular therapy. We can start with the antibodies because acute lymphatic leukemia was the first disease in which a very good antibody, which called blinatumomab, which is a bispecific antibody or T-cell engager, because the antibody has two arms. One connects to the immune system of the patient, and the other one to the malignant cells. So one is against CD19, which is a protein on the leukemic cells, and the other is CD3 on the immune system. And this is very powerful antibody. It was the first bispecific antibody. Now we have few of them in other diseases approved by the regulatories, FDA and EMEA, both for myeloma and for lymphoma, that are other types of lymphatic cancer. So blinatumomab is very effective in inducing the patient in a state of MRD negativity, which means measurable residual disease negativity. It means that they don't have even one malignant cells in 10 or 100,000 or million of cells. So this is for the immunotherapy, humoral immunotherapy in ALL. And the other development, and we have two types of these antibodies. One is for the antigen CD19, and the other one is inotuzumab for CD22. And these are the first example of good antibodies against lymphatic malignancies, beside an old one, which is the rituximab or MabThera, which is only one arm. And the second development is CAR T cells, which is engineered lymphocyte of the patient, so it's autologous, that we have the machinery or the engine of the T cells, but the specificity of antibody. And so the specificity is again the same antigen or protein, CD19, on the malignant cells, and the CAR T cells is working against the malignant cells and have very little side effects, and therefore it's much easier and less toxic than transplantation. So at least for acute lymphatic leukemia, there is really a revolution in the field. There are a new mode of therapies that can give hope to the patient, that can cure the patient, and it's adult patient, because the result always in children with lymphatic leukemia, ALL, was much better. And in some places in the world, not in our center, but other centers, they are going away completely from transplant and treating the patient for a long time with protocols that include only chemotherapy and the monoclonal antibodies and CAR T cells. So they really revolutionized the field, and for patients with adult ALL, in which the disease came back until a few years ago, there was no hope. Now we are able to cure many of these patients. So this is marvelous time to be there, and really good news, beautiful news for the patients. There are challenges for CAR T cells, so chimeric antibody receptor T cells, in other diseases, because one of the success of the CD19 CAR T cell is the antigen. So this is very good antigen for the CAR T cells, and there is very few off target. It means that the CAR T cells is working only against the malignant cells of the leukemia and not against other tissue or other cells. In other diseases like acute myeloid leukemia, it's much more complicated because there is no such optimal antigen or target for the CAR T cells, because most of the antigens that are on the malignant cells of the AML or myeloid leukemia, like CD33 or CD123 or CD44 and many others, are also on normal myeloid cells. And therefore, when we give CAR T cells to a patient, even the best CAR T cells that we have, most efficient CD19 for ALL, this also work against normal B cells or normal B lymphocytes that express CD19, and therefore the patient has to, his immunoglobulin in the blood go down, and we need to give him immunoglobulin, her or him immunoglobulin after the CAR T cells. But in AML, this is not a matter of immunoglobulinism, it's a matter of aplasia. So the normal myeloid cells are going down, and then the patient is prone to infection and to other risk. And therefore, CAR T cells in myeloid malignancies and is much less developed. Actually, there is no commercial product approved CAR T cell for AML. All the centers, all the world are trying to develop CAR to acute myeloid leukemia, and this is also true for B-specific antibodies. There is no approved yet B-specific antibody against acute myeloid leukemia. There is antibodies, but they are hooked to kind of chemotherapy, and not to, they are not only immunology, but chemotherapies that, due to the specificity of the antibody, like anti-CD3, are attacking only the blood cell or the malignant cells, but they are not immunotherapy. They are antibody, but they are hooked to chemotherapy. So in AML, the CAR T cells and immunotherapy are in infancy, but we are sure that it will come, but it's much more difficult. And in many conventions, and there are many talks, where are we with immunotherapy or cellular therapy and humoral immunotherapy in AML? We, as you know, found out that a very rare type of AML, this is about 1% of all the acute myeloid leukemia, the blood cells, the malignant cells, are with specific translocation, 821, in which part of the chromosome 8 moved to chromosome 21 and part of the chromosome 21 moved to the 8th. So this is called translocation, and they express the same antigen CD19 like ALL, and we treated a few patients and also published it with the CAR T cell CD19 in AML. But it was not extremely successful. So patients respond, but we had to come with transplant in order to cure them for the long run. So there are studies with CAR T-cell in acute myeloid leukemia for the CD44, in Italy for the CD123, for the NKG2A, and other antigen, but they are not so successful like the CAR T-cells and antibodies in acute lymphoid leukemia. But I'm sure that with time will come, and we will also have immunotherapy in AML, because the immunotherapy is the way to go. And if we will know how to play or manipulate or focus or target the immune system against the leukemia, I believe that this will cure not just the leukemia, but also solid tumors, which is another story. There is a small clinical trial that only few patients, and the results are not terrific. So there are clinical trials, but this is not a panacea yet, not a breakthrough. So this is different scenario, because autoimmunity is not malignancy. So in principle, this is chronic disease and not lethal disease. Of course, there are complications for the various autoimmune, like scleroderma, lung disease, and liver disease, and cholangitis, but this is not considered malignant disease. So I would say that the ball game is different, because if in cancer, the physician can take some percentage of failure, or we say mortality, for a patient with a doctor rheumatoid arthritis, he is not used to it. And therefore, the issue started many years ago with transplantation in autoimmunity, because with transplant, we knock down the B cells. The B cells are, with B cells, but many other cells are part of the autoimmune, the pathogenetic of autoimmune diseases, with the production of autoantibodies with plasmablast and lymphoblast and the whole cascade. And actually, the development of the immune system after transplantation is a recapitulation of the ontogenicity. So the B cells and other immune cells that are coming from the donor and then are developed after the transplant are naive and don't recognize the autoantigens, and they are not producing the autoantibodies. And so in transplant, the idea was that with the chemotherapy, you killed all the cells that produce the antibodies and the autoantibodies, and now you have a naive new system that is not producing the antibodies. However, transplant didn't catch up in autoimmunity, although there are few hundreds in every year, and there is even working party in the European EBMT, European Bone Marrow Association for blood and the marrow transplantation for autoimmunity. But it's usually too toxic. Now, the CAR T cells have advantage because they are knocking down the B cells, but they can also penetrate the lymph node, the neurological system, and the other tissue, and the kidneys, and therefore they are very successful. And the first disease that most of the CAR T cells were given patients with lupus. So this started about 4 weeks ago in our best journal, New England Journal of Medicine, was description of the first patient that failed everything in lupus and respond to CAR T cells. And after it, there is more and more patients with lupus that are being treated with CAR T cells with good clinical results. So there are scores for autoimmune disorders that are improving, which improvement of the kidney. So kidney is the organ that dictates the fate of a patient, I would say, with lupus. So the amount of protein in the urine is going down and the lupus nephritis is improving, a complement is going up. So there are laboratory markers and clinical markers which show that the patient is improving. So, but patient selection for CAR in autoimmunity is important because we need on the one hand to take patients that failed the conventional therapy and has an organ injury, okay? Because they are sick enough for trying something new, CAR T cells. On the other hand, this is chronic disease, not malignancies, and we need that the patient will have still organ reserve in order not to suffer or that the CAR T cell will not be too toxic to him. So lupus was the first disease. Now we have, the world have patients with scleroderma that respond to CAR T cells, and some of the neurological diseases like myasthenia gravis or neuromyelitis optica type disorders. So, but in lupus there are, according to the recent report in the meetings that we had in December, the American Society of Hematology, there are about 50 patients at that time, and about a few patients with neurological diseases, and maybe 10 or 20 with scleroderma, but the field is really moving very fast, and there are many CAR T cells, both against CD19, but also against other antigen, BCMA, that is B-cell maturation antigen, that the CAR in myeloma is against BCMA. So there is now question whether a CD19 CAR or BCMA CAR will be the best, and some people are combining the two of this, and also there is the same antibodies, the B-specific T-cell engager antibodies that we spoke about in ALL are also used in myeloma and also used in CAR T cells. So I think also, the field of CAR T cells in autoimmunity is really exciting, more and more patient, more and more hope for the patient, and really it's built the field of CAR in autoimmunity on the experience that we have for CAR for malignancies, for ALL and lymphoma, and the question is it the same? So will the cell dose, the way we give the cell dose, the adjusted medication, the follow-up, the prevention, the things that we do to have monitor, the things that we do after CAR T cell for autoimmunity will be the same as we do in hematology, because the field of autoimmunity is different, and not everything that we are doing in hematology is applicable or the optimal, I would say, for autoimmunity.